Thank you. Thank you for this opportunity to share this information. It's uh, some of it we've never been able to share with you guys before because we didn't have ways to estimate it. But we're going to be looking at where we stand on the 90, 90, 90, 50 measures and trying to give you a little bit of a taste of the profile of people in Texas who are living with newly acquired HIV, who are living with undiagnosed HIV, and looking at where we stand on the proportion of people on treatment and the proportion of people with viral suppression. All right. So we're all familiar with these goals. These are the measures. These are the measures in Achieving Together. We're aiming for 90% of everyone living with HIV to have a diagnosis. We're aiming for 90% of everyone with diagnosed HIV to be on treatment or antiretroviral therapy, ART. And then we're aiming for 90% of people on ART to have a suppressed viral load. We believe in, as it's laid out in Achieving Together, that hitting these goals for these measures, along with robust prevention, including PrEP, will reduce the annual number of Texans with new HIV infections by 50%. So there's your 90, 90, 90, 50. I'm sure you're all extremely familiar with that. But we don't want to get to 2030 and say, you know, or get to 2029 and say, well, are we going to be able to meet these goals? We want to track them along the way. And what we want to be able to do, if we can, is set up annual targets that, if we meet them, will move us along the road to 90%. Or 50%. When we're talking about this information, we find it helpful to start out with a very big picture, and then we'll break it down to individual components. The biggest picture of all looks at how often people are acquiring HIV infection. Do they have access to the treatment that they need? And are they achieving viral suppression? When we look at this new information, we can see that every 2 hours a Texan acquires HIV, that 1 in 6 Texans with HIV don't know it, and that about 25%, or 1 in 4, of Texans with diagnosed HIV are not getting the treatment that they need. Oops. So we tend to look at the cascade, or we have looked at the cascade as a sort of or a care continuum, or the story of a person with HIV in a very linear way. The story of a person, the story of HIV treatment for people living with HIV starts with a person acquiring a new infection. And then the story goes, and then they get a diagnosis, and then they get on ART, and then they have a suppressed viral load. Oops, sorry about that text thing there. But we know actually that this is it's not a straightforward or linear process. There's a gap in time between the time that most people get an acquire HIV, and when they get a diagnosis. And that gap has implications for them and public health implications for our communities overall. We also know that most of the time, once people get on ART, that they go in and out of care or on and off ART for various reasons, and that viral suppression isn't a given. 1 year, a person may have a suppressed viral load. The next year, they may not. All these gaps and cycles through systems have implications for that person's health. It also has implications for the epidemics in our communities overall. So here's about the biggest picture that we can offer you. So using our new techniques, we estimate that in Texas in 2017, there were almost 108,000 people living with HIV, and that was people diagnosed and undiagnosed. So we'll sort of turn the care continuum or the care cascade on its side, and we're going to look at what powers the further transmission of HIV. Because in that same year, there were about 4,600 Texans with newly acquired HIV. So let's look at what powers that continued transmission of HIV. Well, about 50% of all people living with HIV in Texas have a suppressed viral load. So we know there's no transmissions from that, and we also know that that's achieving the highest level of a treatment goal for about 50% of all people living with HIV. So let's look at a profile of people that do not have a suppressed viral load. They had HIV in 2017, but they didn't have a suppressed viral load. Well, 16% of all people with HIV were living with an undiagnosed infection. About 19% of all people living with HIV had a diagnosis, but they were not in care and treatment. They were not on ART. And about 15% of all people who were living with HIV had a diagnosis. They were in treatment, but their viral load was not suppressed. All right? So we know that the chances of transmission at each one of these stages here, being undiagnosed, not in care, or in care but without viral suppression, has a different chance of further transmission. For example, for every 100 people living with undiagnosed HIV, we would expect between 6 and 7 transmissions of HIV from that group of people across a year. It's lower for people who have a diagnosis but who are not in care. And we expect about, for every 100 people who have a diagnosis but who are not in care for their HIV, we expect about 5 transmissions a year. And then even lower for people who are in care but whose viral load is not suppressed, we expect about 2 transmissions a year. So when we look at those odds of transmission, and then we look at it in the context of how many people are at each one of these stages, we can make a sort of prediction about the proportion of people with new infections, about sort of where those infections may have come from in terms of these stages. So for the people in Texas, for the Texans with newly acquired HIV, we think about 2 out of 5 were associated with people that did not have a diagnosis. About 2 in 5 were associated with people who were in care, who had a diagnosis, but who were not in care. And about 12% were associated with people who were in care, but whose viral load was not suppressed. So I just threw a bunch of information at you. Let's pause here and see if you have any questions or comments about this particular analysis here. Okay, we'll be coming back to this in the future. So, and again, I don't know why some of these things are too big. So let's start. We're going to start with the last measure, the 50% measure. But we're going to start with new, people acquiring new infections. So we want to cut that annual number of people acquiring new infections by half. Let's look at a little bit about what that would entail. So where are we starting from, and what's a brief history of it? Well, from 2010 to 2017, Texas didn't have any changes in the number of people acquiring HIV every year. It's about 4,600. And you can see these little red dotted lines. Those are the guardrails. Now, because this is an estimate, there's always, it can always bounce up and down a little bit just by chance. But as you can see, every year is firmly within those guardrail limits. So Texas has had about 4,600 people acquiring new infections every year between 2010 and 2017. Now this means we're going to have that pulling it down is going to require some extraordinary changes in the way that we do prevention and treatment and care, and the way that we look at the challenges associated with each one of those phases of our work. So I can give you a little bit of a profile of the 4,600 Texans with new HIV infections in 2017. 3 out of 5 were gay and bisexual men or other men who have sex with men, and we're going to use MSM as a little shortened name for that group. We see that 13% were among women who have sex with men, and that about 8% were associated with injection drug use, and then all other groups made up 14%. So that would be men who have sex with women, pediatric transmissions, other transmissions. Okay. We can see that that more than 3/4 of people with a new HIV who acquired HIV in 2017 were either Latinx or Black, and that we can see that the largest group of people who acquired new HIV were between the ages of 25 and 34, with about 1/4 of people acquiring HIV falling into the category of youth, which we would say is 13 to 24 years old. So let's look at other ways to break this down. And this again is the people in Texas, the Texans who acquired HIV in 2017. About 30% are Latinx, gay and bisexual men and other men who have sex with men. 20% were Black MSM, and 10% were white. So we can look at about 3 out of 5, a little bit more than 3 out of 5 people who acquired HIV were gay men in these groups. We can see that the profile of people who acquired HIV in 2017 tracks geographically what we would expect, with about almost 50% either from Houston or Dallas, and the TGAs accounting for between 7 and 8% each, and that the remainder coming from the rest of Texas. Do you guys have any questions about this little profile? Okay. So let's get into the meat of this. If we want to reduce the number of Texans who acquire HIV every year, if we want to reduce that by 50%, then let's look at what the targets would have to be to get there. So these are projections based on those trends that I first showed you about, what was happening from 2010 to 2017. Because that's flat, the expected number of new infections, if we trend it out, this is just an extension of our current trends, it's flat. So what that means is that to reach these targets, and that's the blue line, then we're going to have, as I said, we have to have fundamental disruption and fundamental changes in the way that we approach these issues, or that we approach the way that care is delivered and that testing is delivered and that prevention is available. So this is a sort of a daunting slide. Do you guys have any questions that you want to ask about it? Okay. Oops. So before we go on, just to look at this again, if we want to drive down the number of people who acquire HIV every year, we're going to have to pay particular attention to people who are living with undiagnosed HIV and people who are living with HIV but who are not in care. So let's look at what percentage and how many people living with HIV know about their infection, or conversely are living with undiagnosed HIV. And remember, we want to get that, as you know, to 90%. So here's just a little visual. It says here's all people living with HIV, whether they have a diagnosis or not. And here's the people with the diagnosis, and we want to get this piece to 90%. So here's sort of historic data and then a jumping off point. This is the path to 90%. In 2010, we were at 80%. 4 out of 5 people living with HIV had received a diagnosis. By the time we got to 2017, we estimate that 84% had a diagnosis. But 84% is not 90. We want to get to 90. And so what we did was just break the remaining 5.7 percentage points between 84 and 90 into equal steps. And so you can see that in 2022, we would be aiming for about 86. In 2026, almost 88. And that would get us to the 90% that we want. Okay. So obviously, as we get to that diagnosis ratio, I just want to remind us that that means the overall number of people living with a diagnosed HIV infection would rise a good deal. So here we were in 17 and 18, and then by the time we meet our goal, we predict that there will be more than 135,000 people in Texas who are living with diagnosed HIV. And that has obviously implications for how many people will need treatment, what our treatment systems would look like, how many people will need other kinds of support, and what this in sort of community level challenges that will be associated with keeping so many people healthy and safe. All right, so the easiest way to think about what we need to do to get to 90% diagnosis is to look at how many people would need to get a diagnosis every year to reach that goal. So we're going to be looking at the number of Texans with a new diagnosis and what that will take to get us to that 90% goal. So here's the number of new diagnoses, a projection of the number of new diagnoses that we would see if we just continue on our current trends. Okay, because when we've been talking about HIV numbers and where the epidemic is going, one of the things that we've always talked about is, wow, the number of people getting a diagnosis every year is very flat. So that's that. So you see that here. What we'll have to do, though, as you look at these targets, is we're going to have to increase the number of people living with HIV every year to be able to get to that target. So what I want to pause for a minute and let you kind of look at how these targets rise and ask if you have any questions about that.
Hi, this is Daniel. I've got a couple comments on this particular slide that I think is important for us to sort of understand. Given the emphasis on the achieving together goals of increasing routine opt-out screening, there is a chance that those will rise considerably if we are really doing routine screening to find out, to identify those undiagnosed individuals. And so it won't mean that there is a problem that is maybe much worse than what we thought about. It's just going to be, we'll be identifying more.
Yeah.
I think it's important to even think about sort of how that's going to impact the opportunity given this particular slide that you just brought up. I appreciate you jumping that, because I think one of the things that is going to be important for us to understand is sort of what happened between between 80 to 81 and then 81 to 84. And I say that because is it that we were able to get more people into care because there were more access opportunities? Was it better linkage to care? What was it? Because I think we have to understand that in order to figure out what we may need to do if in fact we are able to identify many more of those undiagnosed, so that we can continue to meet those goals of trying to get people, trying to meet that 90% goal.
Right. I think maybe in the future we'll have an opportunity, or if y'all are interested in digging in more, it's a very interesting dynamic because the actual number of people who are living with undiagnosed infections really hasn't budged that much. It's about 16 to 17,000 Texans living with an undiagnosed HIV infection. So there's a lot to unpack with this, and as we go forward, I'll try to give you a little profile of what that looked like. But before we get to that 2017 profile, I just want to, sort of illustrate that what we're talking about is, here's the dark blue. Those are sort of the expected diagnoses that would be made if just current trends continued. And then at that top, you can see how many more diagnoses will need to be made to reach those annual goals. And of course, Daniel is right. If we exceed those goals, we will get, in terms of diagnosis, we'll just get to that 90% goal faster. So if we diagnose more people than is shown here as the targets, then we'll just get to 90% faster. And I know sometimes people look at increasing diagnosis and say, oh, that's a problem. The fact is what we're doing is we're catching up. We're catching up. All right, let's look at a little profile.
Hey, Ann,
okay. Yeah.
There's a question in the chat.
Okay.
So if widespread prevention efforts such as PrEP have greater impacts, then would it be possible for the numbers to remain similar, but account for larger percentage of people living with HIV?
Okay.
So I think the implication is that if we have decreasing new infections,
yeah,
the number of new diagnoses, could that remain?
That'll shrink it. That would shrink it. That would shrink it. It would have some impact.
I agree. This is Daniel. I agree that it would have some impact, but I don't think it'll have that big an impact.
Why do you think that, Daniel?
And the reason is I think that for those that go undiagnosed, that holy grail, that 20% that we're after, those are the individuals who are not accessing healthcare on any regular basis, either because they are uninsured, underinsured, or in some cases, like myself, you're a male, and males typically don't access healthcare until you're on death's door. So I think that those individuals who are going to access things such as PrEP or whatever are probably not in the group that we're looking at in terms of identifying in terms of those undiagnosed.
Let's look at
some impact, but I don't think it'll have a great impact.
So Daniel, that's a interesting point. So what you're saying is, look, the demographics don't line up. The other reason it's going to have a small impact is that what's being added to the undiagnosed pool and being drawn from the undiagnosed pool every year is only about 4,000 to 5,000 people. So the majority of people, yeah. So yes, PrEP is very important, especially for those the folks that are looking at it and considering it as a very important part of their health care. But as we let's look at this profile, and it might direct our attention a little bit more to what the undiagnosed population in Texas looks like. So let's see. So what I want to do is show you the proportion of people in several different groups who have a diagnosed infection, so that we can kind of get at, okay, what is the profile of people living with an undiagnosed infection look like? So for gay and bisexual men and other men who have sex with men, in 2017, we estimate that more than 4 out of 5, a little bit more than 4 out of 5 people knew their status. But that left almost 12,000 people living with an undiagnosed infection. So you can, and then it's a very similar proportion for men who have sex with women. We go, whoop, we go over here. The proportion is very similar, but it's a much smaller group, okay? 11,000, 1,100. And then when we look at these two other groups, people who inject drugs and men who have sex with women, we can see that their proportions are quite close to 90%. So the largest number of Texans living with undiagnosed infections are gay and bisexual men and other men who have sex with men. If we look at it by race and ethnicity, then let's start over here. We estimate that around 90% of white Texans living with HIV had received a diagnosis. The next highest proportion, Black Texans living with HIV, almost or more than 4 out of 5 have received a diagnosis. Latinx Texans living with HIV show the lowest proportion of people living with a diagnosis, and not almost 4 out of 5 people are living with it. And in addition to that, if you look at the number of Latinx Texans and Black Texans living with undiagnosed infection, you can get a good idea about the scale and the focus of activities that would be needed to meet that goal. And then I want to make sure that you see this, because age plays an important role as well. So when you look at youth, only about half of youth with HIV have received a diagnosis. So there's about 3,000 or almost 3,400 youth living with HIV who have not received a diagnosis. But the group with the highest number of people living with undiagnosed infections is actually the 25 to 34-year-olds. And that's the group that we saw, remember in one of the first slides, that in terms of the age of people acquiring HIV infections in 2017, the biggest group was 25 to 34-year-olds. For these older age groups, especially people 45 and older, more than 9 or around 9 out of 10 have received a diagnosis. So if we want to look at like where most of that work on assuring that testing services are available and acceptable to people living with HIV, then we're looking at people who are, for the most part, younger than 35. Okay? So we're talking about gay men, we're talking about Latinx Texans, we're talking about people 35 and younger. And so this is just another way of breaking this down. You can see the large majority of people living with an undiagnosed infection were gay men. Almost half were Latinx, and almost half were 25 to 34 years old. Let's be a little bit more pointed. 37% were Latinx MSM, 21. 1 in 5 were Black MSM, 1 in 10 were white MSM, and about 7%, 7 in 100, were Black women who have sex with men. So you've got fully 3/4 of people living with undiagnosed infections in one of these groups. About 1/3 of the people living with undiagnosed HIV are in the Houston EMA. About 1 in 5 are in the Dallas EMA. And then what you would expect, the share of people living with undiagnosed infections, again, falls along those same geographic areas that we see when we're looking at people living with diagnosed HIV. So I'm going to stop for a minute.
And this is Brian. I have a question. It's been a while since I've been with prevention, but when we're talking about the group at risk, men who are typically Latinx or African American, who are under 35, who typically don't access the healthcare system unless
Right.
some kind of trauma, because they typically don't see a doctor on a regular basis. So
Exactly.
what's the uptake been in the emergency rooms for routine testing? Again, I've been away from the program for a long time, so I don't know, but it seems like that idea, in terms of a strategy, that seems like that would be an important area to focus.
Yes, we should look at that. I think what's important to consider, though, is what you just said. These are young people. They are gay men of color for the most part, young gay men of color. And even emergency room visits are, are not going to be a routine
Right.
place. I think our focused testing programs, as we support them, if they're truly focused and in ways that are that approach status neutrality, that is looking at understanding within the community those young gay men's needs and looking at how to support those needs before a diagnosis, and looking at ways that this is a part of their whole, that this meets their goals, that's in alignment with their values and so forth, is going to be extremely important. So healthcare focused diagnosis strategies have their place because of the particularly large volume. But what I can tell you from looking at the data on our programs is that the folks diagnosed through those programs are older, They're more likely to be Black females.
Mhm.
And the majority of people that have a reactive test result, they've already been diagnosed and they're actually already in care.
I see.
So there's a distinct profile of people that we might be able to identify through routine screening that doesn't exactly match what we're talking about in terms of the profile of people who are living with undiagnosed infections. So,
Okay.
but we also have to think about other strategies that would be useful, such as self-testing and other types of approaches that will make it easier and more acceptable for young gay men to test.
It sounds like in the strategy you're talking about, does that kind of include socialization such that, maybe you should interact with the healthcare system, that kind of thing? And
That's
okay.
That's a goal, isn't it? Yeah. Okay, any other comments? Or I know this is this is the worst kind of presentation where the person just goes bludgeons you with data. Bludgeon. But again, the summary, what we see, what these new techniques allow us to do is to look at more specifically the number and the profile of people living with undiagnosed infections. And again, we're talking, more than 3 out of 4 people living with an undiagnosed infection are in these 4 groups, and that the number of people living with undiagnosed infections geographically falls along the same lines. And again, 3 out of 4 are in the big 5. But there would be different strategies needed for people in these different communities because, as you know, their epi profiles are different. All right. Now let's go to the step where people get on ART. And, oops, sorry. So again, what we're looking for is here's the little egg. Within the number of people with a diagnosis, we want the number and the proportion of people on ART to hit 90%. So here's the path to 90% treatment ratio. In 2012, 67% of all people with a diagnosis, we estimate were on ART. By the time we get to 2017, we're at about 74%, or almost 3 in 4 people with a diagnosis are on ART, but we want to get to 90%. And so here's the trail. We break it down. And these are the percentages we need to get to. Well, if we know that those are the percentages we need to get to, then we can come up with some targets. Okay? So this blue line here, as you can see, we expect the number of people on ART to go up every year. And this is a projection of current trends. We need to bump that up to get to 90%. So as you can see, as we go over in time, we've got to accelerate that trend, right? We've got to go big, go faster. So what this kind of shows you is that the changes in systems, they'll need to happen here. The assessment of systems, looking at how to expand them, how to make it easier to be in treatment, to stay in treatment, so that can be scaled up here. Now, I also want to emphasize that we don't have a crystal ball. We might see the current trend accelerate based on new treatment options, or other things that would make it easier for people to get on ART and stay on ART. So while I do want to emphasize that there's a very important role for rapid start here, what we're talking about for the most part is not people with a new diagnosis. These are people who've been living with HIV for a while. Their diagnoses were made, they were not recently made. And that this is a challenge that you have to meet every year. This is not like diagnosis where we can get to it faster. We just have to stay on track. So even if we exceed a target in 1 year, that does not guarantee that we will meet the target for the next year. Let's see. So here are the additional people that are needed to get on ART to reach the 90% treatment goal. And again, here's your trend in dark blue. And then the numbers in light blue are the additional number of people that need to be on ART in the treatment and care systems to reach those goals. So this makes it really clear that we cannot wait until 2016, 2017 to start making the changes to the systems that would make it easier to get on ART and stay on ART. So I'm going to stop for a minute. This raises questions, that you'll have to ask within your communities and look at it. What does it look like to be a person with HIV who is getting care in our systems? Who are the care providers? What their programs look like? What are the kinds of retention trends that you see in your community, right? Who's most impacted by the different systems? Oops. So any comments about this? I did not break these down because you guys have better access to local data through Ann Dill's packets, which you can reach online. You don't have to be content with a statewide breakdown for this. You can look at your own local profiles and say, okay, who's in care? What groups are not benefiting from care? And then your own local systems. Where are the bottlenecks? Where are the pain points? Where can things get eased up? What kinds of interventions are working to support people with HIV in their treatment? Okay, so now we're going to look at increasing the number and percentage of people on ART who have a suppressed viral load. We want to get to 90%. And so here's what it looks like with the eggs. All people living with HIV with a diagnosis on ART, and then with a suppressed viral load. Here's our pathway to that 90% viral suppression ratio. We can see we started out at about 3 out of 4 people on ART having a suppressed viral load. By the time we get to our jumping off point, it's 4 out of 5 people on ART who have a suppressed viral load. And here's our pathway to get from that 81% to the 90%. It's not as steep as the other changes, but it's based on a higher number of people. So here's the trend in the number of PLWH with suppressed viral load. Here are people living with suppressed viral load, and here's a trend. Here's our numbers based on current trends. These orange figures here, these are the targets. And again, what you can see is we've got, even though this naturally increases, the trend naturally increases over time, we've got to get bigger faster. And just like with looking at treatment systems, examining what viral suppression looks like in your community will give you a understanding of the changes and the profiles of people who might benefit from innovations in the way that care is delivered that would make it easier for them to maintain participation that results in suppressed viral load. Here's the nitty gritty. Here's how many more people that would be needed to reach those goals every year. Okay.
Hi, and there's a question in the chat from Lisa Mataya asking if if there's a systems assessment tool that's recommended, I think, in looking at this and the systems in an area.
I'm going to let other people on the call. Lisa, there's a that's a good question. We'll have to look into that. I think the first step, though, is just a really clear-eyed mapping of you know, what diagnosis, and I'm sure that you guys have done that. I read a paper recently about someone that used secret shopper sort of things to look at where the pinch points were and where it was exasperating and where people fell out. But I get if anybody, obviously in the whole syndicate, has a systems assessment tool that they like, please share it, and we'll scour the literature and contact other jurisdictions. It's not a satisfactory answer, but it's the one we have. Okay, so let's go back. Knowing what we know now, let's go back to that bigger picture and remind ourselves that a Texan acquires HIV every 2 hours, that 1 in 6 Texans don't know that they have HIV, and that 1 in 4 Texans with diagnosed HIV are not getting the treatment that they need. Let's look at one of the treatment cascades that uses all Texans living with HIV rather than just the people with diagnosed HIV. So we can see here that 4 out of 5 people who are living with HIV are aware of their infections. Almost 2 out of 3 of the people living with HIV in the state are on treatment. About the same proportion are on ART, and about 50% have a suppressed viral load. And again, let's look at the whole system. We'll look at that information from a perspective of trying to understand the dynamics that spur on further transmission. And again, remember that there's almost 17,000 people. There were 17,000 people, Texans in 2017 who were living with undiagnosed infections. 20,000, almost 21,000 people in Texas who knew about their HIV infection, but who were not in care or on treatment in 2017, and about 16,000 people who were in care, but whose viral load was not suppressed. But they don't contribute equally to ongoing transmission. We think that about 4 out of 5 people who acquired HIV in 2017 in Texas, we think about 4 out of 5 of those infections were associated with people who were either undiagnosed or diagnosed and not in care. Okay, well, we can open it up and have more discussion. As Jesse said, this will be posted. Here's my email if you have any questions about that. So let's open it up and talk about what we can talk about. I should have said this at the very beginning. I'm very sorry that I cannot present any information. I didn't have any information that I could present about the number of transgender Texans who acquire HIV every year, or the number of transgender Texans who have diagnosed or undiagnosed HIV infections. The models and the mathematical equations that we were using, we could not use them to estimate the number of people with who are transgender living with HIV that's not been diagnosed or living with a newly acquired infection. We don't have the data we need to be able to get those figures. So I'm sorry, I should have announced that earlier.
Okay, if anyone has any questions, feel free to unmute yourself or type them in the chat.
So one of the issues that come up when we present statewide data is that's great, but people don't live in local communities. They don't live in the state of Texas, if we look at it that way. And I do want to let y'all know that we have estimates for most of these markers for the Part A areas. Those are available. And we're looking to see if we can't do some further geographic groupings so that there could be some more local data on the targets and the proportions of people with diagnosed and undiagnosed infections to go along with the information that you have locally on participation in care and treatment and viral suppression. So how do you think you might use information of that type to design or monitor things going on in your communities?
So Ann, Lisa has asked in the chat, she says, when the CDC director was in Texas, he discussed treating each new diagnosis as a sentinel event. What do you think this looks like?
I think what he meant was, I hope what he meant was, looking with fresh eyes at the parts of the system where we could tighten it up or improve it. If we look at, we don't really need to look at it as a sentinel event. I think we're beyond that at this point, and you got to look at that at the parts of your trends in your community that would be contributing to it. So again, it's a closer look at what's happening with testing in your environment and what kind of bold changes, complete changes in the ways that in the systems that you set up for diagnosis need to be made. So keep doing the things that are working, your focus testing, the routine screening that's going on, but we've got to, I think, from my perspective, the sentinel event sentiment translates into bold, fundamental changes that need to be added to the portfolio of the things we're doing. So doing more of what we're doing is good, but it's not going to get you past that nagging, flat new diagnoses. Okay.
And this is Brian. One of the things that happened last month, I think, from the treatment prevention perspective, is the Planning Council for Houston voted to begin looking at telemedicine. So I know Heather's on the call, but I think it's exciting because part of what's going to happen now is the clients are going to begin to demand that modality of healthcare delivery to them because it meets many patients where they're at. Retention, things like that. So I think it's going to be exciting to see what happens in Houston. They're going to start small with outreach, but the definite position of their folks at that meeting was patients are going to begin to demand that type of care delivery modality. So now it may help unfreeze some of the things, because I think a lot of not just providers but patients didn't really know that this was an option for care delivery, and many physicians don't even know it's allowed by law.
Yeah, so that's an example of it's not, telemedicine is not new or shocking, but has it been used to the degree that has its benefit been maximized?
Mm-hmm.
Because do you think your traditional, like, in-person clinical services through the current delivery system you have, could they handle the increased number of people that we showed would need to be served?
Probably not. And so we have a physician here in Austin that he's doing one of the things that in our telehealth guide that's been moved forward to management for approval is allowing for delivery of HIV care directly to the client. So for example, there's a physician here in town in Austin that's doing follow-up visits to clients on their smartphone at home or on their tablet. And so that does a couple of things. One, he says that it cuts down on patients being disenrolled because they can't keep appointments. Patient satisfaction is great. It's not a visit that they need to put hands on the patient to see them. And then the other part of that is it also creates an opportunity. If you look at their typical panel would be 24 patients a day, and if I can move those out in an in-person format, if I can move 8 to 10 of those out, it creates not only more access for those really critically ill patients that need to be seen in person, you still see the same amount of people, but you've disrupted it, and so that the typical model where we have the patient come into the clinic and all of that is changed. So you do create capacity so that when more patients are added, you have a way for the system to accommodate this, because many times these visits can be done, the follow-ups on your smart can be done after hours or at lunch. So that it's really very flexible. So that way it creates a space in a system that's already overwhelmed, a way to make that work.
So yeah, so that is a very good example of thinking about how that additional capacity can be created. And as Lisa pointed out, you're going to have to walk through your whole system and say, okay, what is it about enrollment? Because, you know, a lot of these folks, they are going to be enrolling in the ADAP, right? Is our system set up to accommodate more people? Is our system set up to accommodate rapid start? Or whether we're talking about, you know, the ADAP or a local care system, you know, what needs to be done to streamline that process? How can we make it, as Brian was talking about, make it so easy for people to keep follow-up appointments, right? Remove administrative barriers. We're going to be at the state level looking at those issues. Where have we put barriers? And I know you at the local community levels are going to look at it that way too. But again, just like with diagnosis, we're looking at significant changes in addition to doing the things that we've been doing that are well serving people, as we can see with increasing numbers of people with viral suppression. How do we make those outcomes available to a lot more people? So that is a fundamental change. Other questions or comments? We can go back to any of the pieces of this that we want to. So let me ask you a question. What pieces of this do you think have the most were most helpful? What pieces of this would you like to see further exploration of?
And this is Jorge Salazar in El Paso, La Fe.
Yes.
Good hearing you again.
Yes, you too.
Listen, two pieces, two concerns. One is the great number of Latinos, Latinx that comprise both those that are diagnosed and not aware of their status and those that are not in care.
Yes.
If you trace your data with the anti-immigrant sentiments that are coming from our national and local scenes, a lot of Latinos are now afraid, both from the standpoint of immigration, but even from the standpoint of public charge,
Yes.
that entering treatment might have repercussions both for their immigration status and that of their loved ones.
Yes.
Because we're seeing that in our FQHCs as well.
Yes.
So I think a strong effort to educate the Latino population around how you can access care without these concerns, and the piece of confidentiality that has always been, I think, a trademark of HIV care, reminding them that what we do in HIV is a public health service and so forth, I think is a very important approach. The other piece is something that you and I and the rest of the state have been discussing for quite a while, and that's the needs of the border community as a cohort, as opposed to individual regions or cities. The border communities tend to have good viral suppression rates in general, but we're reaching the segment of the population that accesses public programs and Ryan White programs, and we're still not quite reaching the populations that might be here, and I not limiting it to the undocumented, but those that are in mixed families, as they're now being called, mixed immigration status families. So I think we still have in the state of Texas, and especially with having the longest US-Mexico border section of all the other states, a lot of work to do along that piece that would have repercussions on all Latinos accessing care.
Yes.
I know that the syndicate has picked up the piece around cultural sensitivity and so forth. Well, it goes a little bit further than speaking Spanish. It goes to the effort of trying to get our fellow Latinos into treatment where they don't have to worry about the other issues that come with being Latino in Texas. And because they are part of that population that could possibly spread the disease and impact our projections of what we need to do to reach that 90% goal.
Yes, and what you're illustrating very vividly is the whys. So this information can give a fact, but an insight only comes from your intimate knowledge of your community and your clients and the people that you would like to be clients, but cannot or have not been your clients. That's awkward, but yeah, those are important considerations to look at. And so if you have a population who is hesitant to even have a test because of possible repercussions, you can look at where you said cultural sensitivity, meeting people where they are, understanding the threats. But we can look at other things. We've not talked much about anonymous testing in the last few years. Is that something that would help? making people aware of the option that they have to test anonymously. And of course, y'all know much more than I would, but given this profile, given this life circumstances, given the community circumstances, what makes sense for a border community may be very different from what makes sense in an urban or a suburban or even a rural area in terms of assuring that people can access testing services and use testing services and then get the care and treatment they need. I just, at the risk of being ending on a down note, I just feel like that this is the reality that we've got to think about. You know, when Dr. Redfield said that we need innovative disruption, and when you hear our federal partners and local partners and advocates and policymakers talking about the kinds of changes that'll that are needed to bend and change the course of the epidemic, then we are talking about some, as I said, and as you've said before, it's a fundamental course correction. So that means openness. And again, we have to look, we'll be looking at our postures and at the state level, and we hope you'll be able to look at the facts about what's happening in your communities and, you know, look to each other, look to other states, cities, look within your communities, listen to people affected by HIV, and collaborate with them to change these trajectories and change these systems.
Thanks, Anne. Are there, before we wrap up, are there any last questions or comments? I know Helen, I think, has jumped off, but before she did, she had made a comment about she needs some time to assimilate the data, but generally many of the fast track and task force strategies will help. We need increased strategies to eliminate stigma, or all the tools in the world are.
Yes, I should have said that. Yeah. No, absolutely. And again, data want to be free. They want to be helpful. They want to participate in creating solutions. They want to move from being facts to being insights. So again, we'll be working we'll be putting together strategies for making sure this information gets out, that it's available to people who might be able to use it, and how to integrate it with the information that Ann Dills puts out on a regular basis about local conditions when it's possible.
And Mel has typed in the chat, one of the things that our agency has had success with in working with immigrant communities is working with a local immigration attorney to do workshops about their rights. So I think that is a good strategy for folks to look at, is locally reaching out. I know that across Texas and across the border, there's a number of organizations that are working with immigration attorneys and refugee organizations. So reaching out to those, and then we can continue at our level to think about and reach out and provide information as we learn more.
Fantastic.
Any other last comments or thoughts before we wrap up from anyone? Okay, great. Well, thanks everyone for joining us.
For sharing your time. All right. Have a great day, y'all.
As we said, the recording and slides will be made available in the next few days after we've cleaned everything up on the Achieving Together website. And if you have any questions, feel free to reach out. Thanks, everyone.